All right, well, this is so exhilarating for me. You know, people wonder, how do you get up Saturday mornings? I said, are you kidding? I am so exhilarated, especially when I get to talk to someone who is not only brilliant, but he's just such a friend. He's made my husband's life so perfect with all his great expertise in hips and knees. But Dr. William Leone is here, and thank you, Dr. Leone, for being here. Do I have to say Dr. William Leone, Jr.? Your father's not listening. I know he's in Miami.
As long as you call me for dinner, I'm good. Thank you. Okay. And it's my pleasure being here. It's just very gracious, and it's always fun.
You're fabulous. And, of course, I was thinking about you, and you have been at every Cure Symposium doing brilliant things, and we're still working on the right place to have it again. So you haven't given up, but I'm trying to make this perfect, just like you do when you work on people. You said when you first came in that we talked about what should you be talking about. And, of course, you can talk about your article, Preserving Your Hip and Knee Joints, but you want to do something bigger than that. I like what your topic is. What is it?
Well, I was thinking, you know, what's been my big impression? I've been in practice 25 years, and how has it changed? You know, what was it like in the beginning and in the middle, and what's my impression now? And I think my biggest impression is that people just get well so much faster, and it's such a better experience. It's remarkable. I as you know, I really limit my practice and specialize and hone in on problems associated with the hip and knee, mainly replacing joints, some arthroscopy of knees. But truly, in the beginning, people would be in the hospital 7 or 8 days after a hip or knee replacement, and then very typically go to a rehab unit. And you know, just progressively, they've gone home or gone to rehab earlier and earlier. And in the beginning, people felt like we were taking something away, or they weren't getting what they deserved. And the whole attitude has turned 180 degrees. And very, very typically now, whether you're 30 or whether you're 80, you want to go home. And very typically now, people are going home. If their surgery's Monday, they're going home Wednesday. And now what's happening is they're going home Tuesday. And it's not because we're kicking them out of the hospital. It's because we've all kind of understand that when you need to be in a hospital, you need to be in a hospital. But if you don't, you'd much rather be home. And I truly applaud that. And because we're doing so many more things before to give people information so they know what to expect, so they're not anxious, to truly anticipate pain or discomfort after surgery and preempt it so the brain isn't conditioned and ready for it. It changes the whole experience. I think nothing ruins an experience more than not feeling good. And by us now decentralizing narcotics and doing so many other things to eliminate pain, and we can talk about those, but narcotics are now secondary. And when you give people narcotics, particularly parenteral narcotics, which are narcotics by an intravenous route. We used to give people PCAs, patient-controlled anesthesia, a button to push, and it would dose them a narcotic. And the incidence of feeling nausea or vomiting or even developing your bowel stop working, getting an ileus or urinary retention with those devices is 50, 60, 70%. So by eliminating all that, when I make rounds the day after surgery, it's a delight. It's just a whole different experience. So as I was kind of thinking, what should we chat about this morning? I think it's just how much better it's gotten. And it's because we're doing a lot of things right.
I have a lot of questions. I'm so glad you brought this up. Let's move back 50 years. I know you were just
50 years.
No, I want to go back because I know that you're young, but 50 years, you can still think about that.
But, we could move back 40 plus years, and that was truly the inception.
Okay, let's do that.
45 years, 46 years.
What was it like? What happened?
It wasn't me doing surgery. Obviously, I was a little
Baby.
kid. But no, people would have these massive surgeries. There was tremendous blood loss. They got multiple transfusions. We would keep them in bed, particularly it started with hips. They would essentially be at bed rest for 3 weeks, trying to get everything to heal. And truly now, the routine, what happens whether someone is in their 80s or very young, and whether I'm doing a very complex revision or a simple first-time hip or knee or partial knee, they're out of bed the afternoon walking. And I just can't tell you what that does to someone's whole psyche. It gives them a very clear signal that, hey, I'm good. I can trust this thing. And I make rounds the next morning, and they're frustrated. Well, why aren't I out of bed? And I just love it. They're getting dressed. They're not laying around in hospital gowns. They're having their meals out of bed. It's a whole different way to approach something, which I think is so healthy.
So, Dr. Leone, how did all that come about? So we had surgeons who, same wonderful surgeons. I mean, people wanted to do the very best, but what changed?
I think a number of things have changed. No doubt our techniques are much, much more refined. We owe everything to these brilliant people that all came before us, and we keep chipping away at it. And you chip away for 50 years, and you come up with something that looks very different. But there's no question we stand on the shoulder of geniuses. I mean, we just do. And we keep modifying their true insights and breakthroughs. Our pain management, our anesthetic drugs are much, much better. The vast majority of my patients, unless there's a real contraindication, either emotionally or physically or for some reason, but the vast majority of people have a simple spinal. Because if you have a simple spinal, you get a lot less drugs. And nobody puts a breathing tube down, and nobody paralyzes you. And you wake up smoother. And there's something called a dilation of your venous side vasculature during the operation. So there's less bleeding, and there's probably a lesser incidence of DVT or phlebitis or blood clot after surgery. So there's a lot of good reasons for it. But mainly people just don't, and it avoids that nausea, vomiting. And there's nothing that ruins an experience more than just not feeling good after surgery and feeling sick to your stomach.
I have to just say, and I've told Dr. Leone this so much, but we have such personal experience in our family with Bill, who's now 91 years old, and he's walking, and he doesn't run because he never did run, but he walks. We go everywhere, and he's had hip surgery, knee surgery. I think he's had I don't know if it's his hips, his knees for 25 years, and he's in great shape. But I have to say, it took a very special doctor like Dr. Leone, because I have lots of people I see, and they don't walk straight, and they're in pain, and they have to have revisions, and they all say, oh, I went to the best doctor. Yeah, and then you look at them and say, no, you didn't go to the best doctor. I said, we went to the best doctor. And Dr. William Leone, as far as I'm concerned, he's the genius of all of it, and there's more than that. There are some doctors that people say, oh, well, he's the best, but he has no bedside manner. I don't even like him, but everyone said he was the best. Well, I have to say, I don't know, your father and mother did a good job on you, because you have the best bedside manner. You have the sweetest smile. You're so kind. And I'm saying this because I have personal experience with you, and I wish other doctors could capture that. And I don't know how they were 45 years ago. But I have to say, and you are a genius with a lot of your inventions. And I was thinking how doctors 40 years from now will probably be using something that you did, your level and the kinds of things that you've invented. But you somehow were just born for what you do.
Well, you're really kind.
But it's true. I know from very personal experience who you are.
What you said is very real. That people typically who have a joint replacement are extremely grateful, because the operation, when does well, is remarkably predictable and gets rid of pain. So a lot of people love their hip or knee doctor, which is wonderful. That's why it's such an up field to be in. Because they work well. There are subtleties, and the more you do, the more you see, and you understand the balancing and the offsets and the relationships and the tensions. But, those are the subtleties. But even if you don't get all that and you somehow get it in, it takes someone who truly is becoming wheelchair bound or losing their independence or scared they're going to fall, even when it isn't so perfect many times, to someone that says, I am so grateful. So it really, when we look at those surgeries that have had the greatest impact on quality of life, not necessarily longevity, but quality of life over the past 100 years, it's total hips and cataracts. You think open heart surgery, and no, it's so these are surgeries that really make a profound impact on people feeling like they have quality of life, and I think that's what we all really want.
Yeah,
certainly that's what I really want.
Yeah, and you've done it. Let me just, if any of you are contemplating hip or knee surgery, let me give you some information. I hope that you will get in touch with the Leone Center for Orthopedic Care. And the way that you'll do that, you can actually, this is a website. So get your pencils out. This is radio. Remember, this is Pencil Talk Radio. You got to get your pencils out. So this is what you'll look at. Holy Cross Leone Center, Leone. HolyCrossLeoneCenter.com. HolyCrossLeoneCenter.com. Or you can make this phone call, 954-489-4575. 954-489-4575. And if you have the January issue of Boomer Times, you can go to page 7, and you'll see this attractive man, and he has a very, very nice article called Preserving Your Hip and Knee Joints, because that's really important to do that. So we hope that you will make that phone call, and, please don't. I see so many people, Dr. Leone, they're walking around bent over. They don't have scoliosis, as we just said. They're just bent over because they're either in pain from their knees, from their hips, and they keep putting it off. And how long should someone put this off?
I talk to people all the time about when it's appropriate to go forward, and it's such a personal decision, and pain is so real, and it's so varied in terms of how people perceive it, and some really don't, and some are super sensitive to it. But as the surgeon, as the person who feels incredibly responsible, I would much rather take care of someone, try to help someone, really intervene very dramatically and strategically with the surgery when they're not as far behind the 8 ball as when they're so down and out that it's now recovery and reaching and much less predictable surgery. That be said, I think with this other gentleman who was speaking regarding scoliosis was right on. I mean, you don't jump right to surgery. There's a lot of conservative, appropriate arrows or quivers to pull and shoot before you say, okay, I've tried this. But at some point, I think it's a feeling and a sense we all get from within our own soul, within our own heart. We're kidding ourselves. Enough is enough. And we all have different triggers. For a lot of guys I take care of, all of a sudden they can't get up after a business meeting, or they can't play golf with their friends, or they can't walk through an airport, or you can't have relationships with your significant other because it hurts, or you can't just enjoy walking your dog, but it's something. And at some point, someone says, I'm tough, but I'm not. Enough is enough, and then they start looking for help, and then they kind of have to decide in their own heart, not just when everyone else wants them to. Something
you said, I remember to Bill too, that when you're favoring a particular side of your, whether it's your hip or your knee, it's causing other problems to now exacerbate, which wouldn't have done if you had taken care of it, right?
Absolutely. The hip bone's connected to the knee bone, but it's truly true. And when the mechanics are changed and the other joints are being loaded in a less than physiological manner, they hurt. A lot of times when joints really become arthritic and they become really stiff, they hurt less. But then it can affect the back, and it affects the gaits, and it affects the knee and the ankle and all that. So that's, and Anita's kind enough to get me some water. Thank you so much.
The least I can do. I mean, it's great. He not only operates well, he speaks well, so we've got to keep him speaking. So what you were saying is that, it does.
And so often people come in and they just don't know whether the problem's really coming from their hip or really coming from their back, or they've had a lot of things on their back and they're not getting better. And so often they go hand in hand, because the type of person, the genetics of someone who develops an arthritic hip or knee is so often the same genetics that may predispose them to developing an arthritic spine. And I tell people, so often when I replace their hip or knee and their mechanics improve and the fluidity of their gait improves and their stance improves, their back feels better. You can't promise, but it's really way more times than not. And it just makes sense.
Yeah. Well, I was just thinking about what you said about the, the recovery. You're right. Someone will say, well, I can't be away for 2 weeks, my job, blah, blah, blah. But now, if they do everything you say, because your surgery is going to be successful, but then the rest is going to be up to them if they do the therapy the way that they're told to do. And you're very specific. I mean, that's what I like about you. You have certain rules, certain guidelines, and if you follow this, we're going to be in good shape. And I just have to keep bringing Bill up because Bill had a very serious surgery, the last one with you with the hip, and you might want to talk about that, the bone, how you had to replace, all this bone because it was a very interesting situation. You told him for 30 days you have to stay off that,
I've been really very blessed in that I joined someone who already had a huge joint practice. So I basically, as a young guy, took care of all those cases that then failed, not the primary joints. So I really got really good at redoing and revising and fixing the ones that had been there a long time or the ones that weren't quite done perfect the first time or that may be fractured or had infections or other things happening with them. And that's really allowed me to become a much better surgeon just doing all the other ones because you can do the hard ones. So in the case of your lovely husband, who, by the way, is a remarkable man, he's a novelist, he was a pilot in World War II. He's truly one of these guys that is a guy's guy and a woman's guy, and just inspirational. But, because with time, the supportive bone that supports the femoral component or socket acetabular component begins to eat away. When you go back in to mount a new one in the right position and make sure it's stable, the supportive bone isn't there. So one of the things that has truly allowed us to do these far-reaching surgeries predictably now is to garden or reconstitute our skeleton, new bone. And again, we stand on the shoulders of just so many brilliant people before us with their techniques that they've developed in terms of using bone from other human beings now that have either had their hip done or that have died, and different methods in terms of making sure that those those bone grafts, are as safe as they can be. And now what's happened since your husband's surgery was done is we've gotten much better at, or the manufacturers and the scientists and the doctors designing have gotten much better at now augmenting those deficient parts of the skeleton, not with bone, but with different very porous metals, tantalum or titanium, which kind of mimic the shape of cancellous bone. You have cortical, the really hard outer bone, and cancellous, the spongy bone. And if we can mimic the shape of that spongy bone, and we can put it next to our living bone, and it's an osteoinductive metal, and we set the right environment, and it's not jiggling during the period while the bone's kind of healing and growing into it and onto it, we can now, in a much faster, more predictable manner, kind of rebuild that part of the skeleton which is gone and still put in a stable construct. Advantage is it's more predictable, more immediate. It obviates even the small risk of a contamination or a disease transmission. The disadvantage is truly with the older technique, which I will still use. The older technique truly gardens bone, truly allows our own skeleton to rejuvenate with more bone. So
gardens bone, I haven't heard that term. That's a lovely term.
So when you bone graft, you can bone graft just with the idea of gardening bone for the future, reconstituting bone such as you have to come back, or you can do it in such a way that it needs to serve a structural purpose now, and then once the component stabilizes, then hopefully that bone graft won't resorb. It will also reconstitute through this process of blood vessels growing into it, removing the dead bone and laying down new bone. It's called creeping substitution.
I love it.
A little too technical. I wasn't going to go there today.
I love that. No, I want you to do that because it shows people, really, it's so important what you do. See, before it's, I had a new hip or I had a new knee, but what does that all mean? And when you did the last Cure Symposium, I loved it. You brought all the mechanisms and how you do it. Most people have no idea, and that's why they're afraid, because it just sounds horrible. But when you show them how simple it is and who you are and how you know how to do this. You've done, and I just have to ask you, how many hip surgeries have you done?
Over 10,000. People don't believe it, but it's, when you add 25 years, and I've got a very specialty practice now, but I was doing 600 and 700 a year.
Amazing.
It's just crazy.
But
it's not a volume thing. It's
no,
a quality
I know, but
thing.
but it also shows that you really, you know what you're doing. You've done it.
But I would emphasize what keeps most people from going forward is that fear of pain and that fear of letting go. And I'm not saying I would be any different. It's easy for me to sit back and be the quarterback on this one. When you're really down on the field and it's you. But I think that's why I wanted to talk about that in the beginning. I think truly people do well. There's so much out there in terms of the approach you use and the prosthetic you use. And, it's really much more important to put together the right team that's going to take care of you and in the right hospital that really does that and has a track record. I mean, and then you have to trust someone.
Oh, you have to trust someone.
You have to let go.
But you have to have someone that does care about you after. I have heard this now recently. I'm so involved in this world, and they'll say, well, he did the surgery, I never saw him again, or I didn't see him till I went back. And I know that you're there. That next day, you're there watching over. What is that? Why do you do it, and why do some others not? And you're not I don't want you to and you don't bad enough people, but what is it?
I premised it in the beginning that it's just the whole experience. So it's more than just the surgery. And yes, we do a very good job, but what happens when you are that 1% or that 2% and something happens? And you need to be taken care of, and you need to be able to call someone and they call you back, or you need to be able to call during lunch and not just get an answering machine. You need to talk to a person, or you need to have a team that's engaged in your care. And I mean, we're all at the end of the day just human beings, and it's such a privilege every time someone comes to actually me and says, okay, I trust you, and I sign their leg before surgery and I write yes, and I tell them I will take good care of you, I promise, I will do my very best. And that's really, at the end of the day, there's a very human. Again, the gentleman, and I sat and listened to his interview. I came a little bit early. I think what he said was right on. I liked him. He said, this is very much an art. And he's right. It's still, I just read an article on the different computers, 2 different computers we use for knees and the robot for the partial knees. But, yeah, that's all cool. And, yes, it does make it more precise, more predictable. But it's still very much an art of 2 individuals need to understand what we're going for, what the goals are, what you can expect, what the expectations are, and then help someone through a process.
Okay,
it's human.
And so we're going to do this every month now, but we we have just a little bit of time left, and I wanted to ask you that when you decided to become an orthopedic surgeon, you could have been anything. And I probably asked this before. Why did that attract you?
I was a kid who had a dyslexia, and therefore I was good at art and sculpting, and I wanted to be a surgeon.
And so that was the difference of what could have made.
Yeah, so I was going to be a plastic surgeon, but I made rounds with these orthopedists, and I just thought they had a lot. People got well, and you went managing chronic disease, and they said thank you, and it was dynamic. And then I was going to be a hand surgeon, and I met this guy, Gordy Hill, and I said, wow, all these people come in and say thank you, and they all walk out, and they think he's wonderful. And I said, I can do this. And that was 25 years ago.
And he took you under his wing because he saw something very good in you. That's who did Bill's first hip, as a matter of fact. That was, I think, that's what happened. But, it takes a lot to do this every day that you do it. When you get up in the morning, you take a deep breath, and you do surgery very early in the morning, so you best go to bed early at night.
I do. I'm seeing my first patient truly signing their leg by 6:45.
Yeah.
And
But you said sign their leg?
Well, again, I've been doing this way before it was now mandated, because it's just, but there's so many checks and rechecks and double checks and triple checks. It's like flying an airplane. There's checklists, and it's good. It seems it's sometimes redundant and silly, but it all adds safety. And so every single patient, before they see the anesthesiologist, before they sign their consent, I visit with. And I, again, go over their plan, and I see their significant other, and I tell them I'm going to meet them, and I tell them what to expect, and I literally sign their leg and write yes.
Wow.
And, it's just good form.
That's
Again,
why I have you on the show. You've always been so brilliant. I've loved working with you. You're a very special doctor, and I feel a privilege. Like you feel a privilege working with people, I feel the same way. Dr. William A. Leone, Leone, and you can get him on his website, which is holycrossleonecenter.com, or call him at 954-489-4575. You will not be disappointed. You can call me and I'll tell you all about it. You can talk to Bill. He'll tell you all about it. And I haven't even gone through, and you just don't know this. And we'll do it on another show. But that Bill tried to find the very best person before he even knew you, and wound up in New York at the hospital for knee surgery. They want to put him in a full cast. Oh, you don't even know this story. And then your name came up I think at some luncheon we were at, and the man raved about you, and that's how we even came to you. So, I mean, it happens this way, but now it's all history. So thank you, Dr. Leone. This was wonderful that you talked to us about what you did. So now we next time we'll pick another subject, and we thank you very much for all you do.
Thank you. It's really my privilege.